Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Star Medical Notes. Myself, Dr. Rais. Let's discuss the topic of fever of unknown of origin, or also known as pyrexia of unknown origin. Let's begin with the name of Almighty. First, coming to the definition of fever of unknown origin. Concept and definition. Concept: FUO is not a specific disease but a syndromic classification. Syndrome means group of diseases. It acts as a filter distinguishing self-limiting febrile illnesses from obscure, potentially life-threatening pathologies. So it is a syndromic classification. So over years, the definition of FUO or PUO, pyrexia of unknown origin, has evolved. Okay, so let's see that. 1961 definition, according to Petersdorf and Beeson, it was temperature more than 38.3 degrees Celsius or 101 degree Fahrenheit on several occasions. Duration more than or equal to 3 weeks. No diagnosis after 1 week of inpatient investigation. What was the purpose? To exclude common viral infections and transient fevers. Context: why this definition was made? Because inpatient evaluation is required due to limited diagnostic technologies of that era. So diagnostic technologies were limited at that time. That's why they used to evaluate the patient as inpatient. Okay, so that was 1961 definition. Later it was modified by Durack and Street in 1991. So recognized new patient populations due to outpatient diagnostics, HIV pandemic, and immunosuppressive therapies. So these two persons, Durack and Street, so what they did, they differentiated the patient population into 4 groups. What was the context behind that? Now the diagnostics have improved over time, and HIV pandemic has taken place, and there were use of more and more of immunosuppressive therapies. So accordingly, they have classified the population group of FUO into 4. So number 1 is classical FUO, number 2 is nosocomial or healthcare associated FUO, number 3 is neutropenic FUO, and number 4 is HIV associated FUO. Classical FUO is traditional patient population meeting the original criteria. Nosocomial is fever developing in hospitalized patients receiving acute care. Neutropenic is fever in patients with neutrophil count less than 500 per microliter, nothing but immunodeficiency related. HIV associated is fever in patients with confirmed HIV infection. So these are the 4 populations they described, meaning according to Durack and Street. Okay, let's move on forwards. So what is the latest modern definition of FUO? So modern consensus. So modern consensus. So it focuses more on qualitative. This is based purely on modern investigations, because as we have moved from many years, so diagnostics have evolved. So more on investigations it is based. So evolution: there is a shift from strict quantitative time frames to qualitative criteria. 2022 guidelines, 2024 modified Delphi consensus. So according to this, according to the modern consensus, 3 criteria required. Number 1, temperature should be at least equal to 38.3 degrees Celsius or 101 degree Fahrenheit on at least 2 occasions. Number 2, duration: illness should be lasting at least less than or more than 3 weeks. Okay, this is the changed thing which is there in the modern context, and very important thing, that is diagnostic failure. So diagnostic remains uncertain despite a minimum standard diagnostic evaluation. So there is a minimum set of investigations that should be done, and even after doing that, if you don't get the diagnosis, then that is mentioned as FUO now. So these are known as minimum standard diagnostic investigations or obligatory investigations. So what is the key principle behind that? So these are the 3 criteria of modern definition of FUO. Key principle is FUO classification depends on the quality of investigation, not just the passage of time. Previously it was 1 week of inpatient investigation. No, so that is not there now. So the thing which is more focused now is the quality of investigation. So one note: a patient with more than or equal to 3 weeks of fever, but without basic workup. What is that basic workup? We will be knowing in the coming slides. For example, blood cultures, imaging has an uninvestigated fever and is not mentioned as FUO. Only after standard workup fails does the patient enter the true FUO cohort. So this we should remember. Minimum standard set of investigation. Again, see same thing in an infograph format. So evolution of definition. Fever of unknown origin. 1961 criteria: Petersdorf and Beeson. Temperature more than 38.3 degrees Celsius on several occasions. Duration more than or equal to 3 weeks. No diagnosis of after 1 week of inpatient investigation. These are the 3 things. Main goal was to exclude common viral infections and inpatient workup required because at the time the diagnostics were limited. Later it was modified by Durack and Street in 1991. They recognized new patient populations, outpatient diagnostics were improved, and there was HIV pandemic. Immunosuppressive therapies were utilized. So according to that, they proposed 4 group of population of FUO: classical FUO in traditional patients, nosocomial FUO in hospitalized patients, neutropenic FUO, low neutrophil count less than 500 per microliter, HIV associated FUO in HIV confirmed patients. Modern updates, so it shifts from quantitative criteria, meaning time frames, to qualitative criteria, quality of evaluation. So according to that, more than or equal to 38.3 degrees Celsius or 101 degree Fahrenheit on at least 2 occasions, FUO depends on quality of investigation, not strictly passage of time. So uninvestigated fever is fever more than or equal to 3 weeks with obligatory workup is equal to FUO. So if it is investigation, meaning that minimum set of obligatory investigation is not done, that is not FUO, it is known as uninvestigated fever. Okay, this we should remember. Okay, now there is something also called as inflammation of unknown origin. What is that? Simple. You have 3 criteria. One is fever. Okay. Second is duration. Okay, duration is more than or equal to 3 weeks. Third is minimum set of investigations. So in this you will not have fever. Later you have duration and you have minimum set of investigations and you have raised inflammatory markers. So that is the difference. Okay, so let us see now. So recognition of this thing, inflammation of unknown origin or IUO. Recognition formally acknowledged in 2024 consensus as a parallel syndrome to FUO. Definition: persistent elevation of inflammatory markers for more than 3 weeks in an immunocompetent patient. So this immunocompetency is important. Immunocompromised, it is not immunocompromised, it is immunocompetent patient. Okay, persistent elevation of inflammatory markers for more than 3 weeks. So it is not fever, it is inflammatory markers in an immunocompetent patient without fever of more than 38.3 degrees Celsius and without diagnosis after minimal standard investigations. So instead of fever you have elevated inflammatory markers here. So what are the inflammatory markers? So CRP should be elevated more than 30 milligram per deciliter, or there should be elevated ESR adjusted according to the age. Exclusion criteria: so there will be no fever of more than 38.3 degrees Celsius. So diagnostic requirement: no diagnosis after minimal standard evaluation, MSC you can remove it as minimum standard evaluation, minimum set of investigations, obligatory investigations. Clinical note: etiology and diagnostic approach mirror FUO, meaning the causes which cause the etiologies of this IUO are similar to FUO, and that's why the diagnostic approach is similar to FUO in case of IUO also. Why? Since fever is the only one manifestation of systemic inflammation. So instead of fever you have increased inflammatory markers here. this one thing we should know. What is this thing? I will zoom it. So classification and epidemiology, the changing spectrum. The etiology of FUO is traditionally divided into 4 categories: infections, neoplasms, non-infectious inflammatory diseases, and miscellaneous causes. However, the prevalence of these categories varies dramatically based on geography, based on age, and the era of study. Now, let us see the difference in etiology based on geography and based on age. So, epidemiological shift in FUO. Now, in high income Western countries, so non infectious inflammatory diseases have 30% causes, and infections have 15 to 25% of causes, whereas undiagnosed causes remain 30 to 50% prevalence. Why? Because of better diagnostics. CT, MRI cultures reduce the infection rated FUO. Second one, NIIDs, meaning non-inflammatory non-infectious inflammatory disease complex, often present with fever before specific symptoms. Improved imaging leaves a hard core of undiagnosed cases, many resolving spontaneously. So in high income Western countries, so these are more prevalent than these, meaning infections, and the greater prevalence is in the undiagnosed cause. Why? Because they have improved diagnostics. No, they have no limitations in the investigations, whereas in countries like in developing countries like India, you have limitations, limitation to access for investigations. In low and middle income countries, still infections are the dominant cause, 40 to 50%. Okay, NIIDs, nothing but non-infectious inflammatory diseases. They are the second commonest cause, but they are lower proportion compared to Western countries. Undiagnosed causes has the lowest proportion. Okay, so infections remain the primary drivers, particularly like tuberculosis, brucellosis, and typhoid fever. Tuberculosis, brucellosis, and typhoid fever. Limited access to advanced diagnostics delays the recognition of non-infectious causes. Okay, that's why infections are still the commonest cause in developing countries or underdeveloped countries. Okay. That was according to the geography. Now coming according to the age-related etiology of FUO. In pediatrics, common causes are infections. They are respiratory, urinary, or viral infections. Second common causes, malignancy, commonly leukemia. Remember this one, blood cancer. Third common cause is NIIDs, non-infectious inflammatory diseases. Common is juvenile idiopathic arthritis or pediatric Still's disease. So infections dominate. Malignancy and NIIDs are less common, but they are clinically significant. In elderly patients more than 65-year age, or you can take it as more than 50 years of age, still lower. Okay. So giant cell arthritis, up to 70% of causes of FUO. Second causes tuberculosis, often reactivation of previous tuberculosis. Third is malignancy. So commonest cause of malignancy is Hodgkin's or non-Hodgkin's lymphoma and or colon cancer. So giant cell arthritis, malignancy, okay, like lymphoma and colon cancer, and infections like reactivation of tuberculosis. So one point to note is immune response is often blunted in elderly individuals. That's why they have atypical presentations, meaning afebrile sepsis. So patient will have sepsis without fever, or they may have fever but there will be no leukocytosis. Sepsis without fever or fever without leukocytosis. So that's about age context of causes of fever based upon the age. Now this is 4 categories according to the Durack and Street. So first one is classical FUO. So fever more than 38.3, more than 3 weeks, undiagnosed after minimum standard in evaluations or investigations. Common etiologies include NIIDs like giant cell arthritis, adult onset Still's disease, systemic lupus erythematosus. So these are the commonest causes of classical FUO in a traditional patient who is not immunocompromised or HIV positive. So giant cell arthritis, adult onset Still's disease, and systemic lupus erythematosus. Infections include tuberculosis and subacute bacterial endocarditis. Okay. Malignancy include lymphoma. Miscellaneous causes include drug fever. Okay. Okay. Then nosocomial FUO. Fever more than 38.3 degrees in hospitalized patient, not present or incubating on admission. On admission, it was not there. And remember, this is the important point. The duration is undiagnosed after 3 days after minimum standard evaluation. Okay, 3 days. Here the duration is 3 days. Okay. So commonest cause of infection is Clostridium difficile infection. So if you want to remember this nosocomial FUO, just imagine the patient who is admitted in the hospital. He will have cannulas and he will be given a lot of drugs. So when you remember this, then the causes are easy to remember. So when you give a lot of antibiotics, so there is a risk of Clostridial difficile infection. So that's one cause. So there is a chance of drug fever because the patient is lying in supine position. He is not mobile. So pulmonary embolism is a cause. Catheter associated infections and sinusitis because the patient will have NG tubes. Okay, so these are the common cause. Number one cause is Clostridial difficile infection or drug fever or catheter associated infection or pulmonary embolism. Okay, or sinusitis. This is in admitted patients. Now in neutropenic FUO, fever should be more than 38.3. Neutrophil count is less than 500 per microliter. Again here also undiagnosed after 3 days after minimum standard evaluation. Causes include infections. Mostly these are infections. So bacterial infections like Pseudomonas or Staph aureus. Fungal infections like aspergillosis, black fungus, or white fungus like candidiasis. Then third is mucositis. Okay, so these are the common mainly infections. Bacterial infections, fungal infections, and mucositis are the causes of FUO in neutropenic patients. So aspergillosis, candidiasis, and Pseudomonas and Staph aureus infection and mucositis. Coming to HIV associated FUO, so fever is more than 38.3 here. Now in outpatient more than 4 weeks, or inpatient again same 3 days in HIV positive patient after minimum standard evaluation. Okay, what are the causes? So again here also like the neutropenic causes, infections are the commonest causes. So what are the infections? So tuberculosis is the number one cause. Second is Mycobacterium avium complex, MAC. Third is cytomegalovirus viral infection. Pneumocystis pneumonia, this is a parasite. Okay, then third is malignancy. Second one is malignancy, that is HIV associated lymphoma. Fourth, the last one is immune reconstitution inflammatory syndrome, also known as IRIS. So when you give anti-HIV drugs to a patient with HIV, so the immune system of the patient is activated, it will produce inflammation. So that is nothing but IRIS. Okay, so that may be a cause for FUO in these HIV positive patients. So what are the common infections? Just number one is tuberculosis. Cytomegalovirus infections, pneumocystis, pneumonia infection, tuberculosis, pneumocystis, pneumonia infections, cytomegalovirus infections, and IRIS immune reconstitution inflammatory syndrome or HIV associated lymphoma. Okay, these are the, and Mycobacterium avium complex. Okay. So what is the minimum standard evaluation? We'll know now. So this is a 1-page summary which we have discussed till now. Fever of unknown origin. So 4 classes: classical FUO. Okay, more than 38.3, more than 3 weeks, undiagnosed after MSC. Commonest causes include infections, tuberculosis, malignancy, lymphoma. Third is NIIDs, giant cell arthritis, adult onset Still's disease, and SLE. Nosocomial FUO, more than 38.3, hospitalized patient, not presenting with fever initially, undiagnosed after 3 days. So commonest causes, you just remember the scenario of admitted patient. So Clostridial difficile, drug fever, pulmonary embolism, catheter-associated infections, and sinusitis. Neutropenic patients more than 38.3, neutrophil count less than 500, and diagnosed after 3 days. So mainly these are infectious causes, bacterial infection like Pseudomonas and Staph aureus, aspergillosis, candidiasis, and mucositis. HIV associated SIO more than 38.3 for more than 4 weeks OPD or more than 3 days inpatient in HIV positive patient. Commonest cause include tuberculosis, the most common cause, tuberculosis, or MSc, or cytomegalovirus. So now, 2 causes you remember just tuberculosis or MSc, tuberculosis or MSc. Other causes include pneumocystis, PCP, pneumocystis pneumonia, cytomegalovirus infection, lymphoma, and iris. Okay. Okay, now, so we have learned about this. There is epidemiological shift. High income countries, the most common cause is NIAIDs, more than 30%. Infections are second common. In low and middle income countries, 40 most common is infections, then come the malignancy and NIAIDs. So why this? Because of better diagnostics in high income countries. So infections related FUO decreased and autoimmune plus true undiagnosed population increase. Age group in pediatrics, infections are far more common than malignancy like leukemia or NIDs like juvenile idiopathic arthritis. Infection dominates. In elderly, you can take it as more than 50. Giant cell arthritis, okay, tuberculosis, okay, lymphoma, and uh, tuberculosis reactivation, lymphoma, giant cell arthritis. And one thing to remember is blunted immune response. So they will have fever but without leukocytes, or they will not have any fever but they will have sepsis. Okay. So one, how to, now all thing we have seen. Now how to move. So step 1 is just you confirm the true FUO based on fever, duration, and MSC, minimum stand investigation. Then classify according to the category. Now the duration depends upon the whether the patient is traditional or admitted or not. Okay. So how do you classify? Classical, nosocomial, neutropenic, and HIV. Then third thing is you take the context based upon the geography, age, and immune status. Then think in 4 buckets. What are the 4 buckets? 4 buckets are infections, number 1, okay, then NIAIDs, okay, then malignancy, okay, then miscellaneous like drug fever. Okay, these are the 4 buckets. Now thing to remember here, ultra high yield memory frame. FUO is category, okay, context based on the geography and age, then core 4 causes. So 3 things you should remember while evaluation. You take the category according to the Durack street, then context based upon the geography and age, then causes. So these 3 things you should keep in mind while evaluating a patient with FUO. Category of the patient, geography and age, that is causes. Category determines urgency. Geography shifts infection proportion. Age alters differential diagnosis. Okay, always think of infection first, then autoimmune disorder, then malignancy, then drug. This should be the thinking process in the mind. Okay, so this much we have learned. Now coming to the differential diagnosis of this FUO. Okay, so we can remember the causes of FUO or the differential diagnosis. So previously I said big 4 causes. Okay, in that big 4 I discussed number 1 infection, okay, number 2 I discussed NIAIDs, meaning non-inflammatory infectious inflammatory diseases. Number 3 I discussed malignancy. Okay, number 4 I said miscellaneous causes. So big 4 and big 3 and little 3 here means, so these 3 are known as big 3, okay, and this miscellaneous, which includes drug causes, factitious fever. So one is drug fever, factitious fever, and one is habitual hypothermia. So some patients, they have their bodies like that, they will have increased temperature all the time, habitual fever. So these 3 are known as the little 3. That's all, no more confusion. Okay, now we will move forwards fast. So differential diagnosis can be divided into the big 3 and the little 3. The differential diagnosis of FUO encompasses over 200 conditions. So very difficult to remember. That's why organizing them into big three like infection, NID, malignancy, and little three, that is drug fever, factitious fever, habitual hyperthermia, helps structure the clinical thought process. So coming to the first big three. In the first big three, it is infections. So even in the West, infections remain a critical must rule out category because they are treatable and potentially communicable. So what are the common things we should consider in infectious of big three? So just imagine, you have an imagination, sorry, you should have this in your brain. So this is the chest, this is the abdomen. Okay, this is chest, this is the abdomen. So common causes include, number one is tuberculosis, so it is chest cause. Infective endocarditis, again it is chest cause. Acute abscess in abdomen, this is abdomen cause. Okay, osteomyelitis in limbs. Okay, so if you remember this imagination of this a human in your mind, so the chest cause, abdominal cause, and the limb cause. Then comes the two other causes like viral causes and zoonosis. Okay, after this the two others are viral and zoonosis. Okay, chest, abdomen, limb, and viral and zoonosis. So these are the common infectious causes of fever of FUO, unknown origin. Now let us look at one by one. TB, it's a great mimicker. Extrapulmonary or miliary forms often lack pulmonary symptoms. Example include bone marrow, liver, lymph node involvement the patient may have. And we use this tuberculin test or the IGRA, nothing but interferon gamma release assay, traditionally known as quantiferon gold test. So these two tests we use to rule out, to suspect a tuberculosis in patient. This PPD, meaning tuberculin test, is mainly used in the children's, and IGRA is mainly used in adults. Okay, but these two can also be negative in patients with miliary tuberculosis due to anergy. Okay, and they may have some lymph node, bone marrow, or liver involvement. That's all. Bone marrow, liver, and lymph involvement. Second cause of the chest is infective endocarditis. So culture negative cases, like 5 to 10% of infective endocarditis who have culture negative, so they can present with this FUO. Why these culture negative cases? The culture negative cases may be because the patient may have utilized utilized antibiotics before, which is the most common cause of culture negative infective endocarditis. Or the bacteria may be such that it cannot be grown in the culture medias, like HACEC organisms, HACEK, HACEC. What is HACEC? H for Haemophilus, A for Aggregatibacter, Haemophilus aggregatibacter, C for Cardiobacterium, E for Echinella, and K for Kingella. Cardiobacterium, Echinella, Kingella, Aggregatibacterium, and Haemophilus. These HACEC group of organisms cannot be grown in culture. That's why these may be the cause of infective endocarditis, and you will not be able to find from blood cultures. The most common cause is use of antibiotics, so because of which you will get culture negative infective endocarditis. So what you will do, you will stop the antibiotics for 24 to 40 hours. After 40 hours, again you will take the cultures. So in that cultures you may get some positive organisms, or you may not get if these organisms are present. These are also known as fastidious, slow growing organisms. Fastidious organisms. Okay, that's a group of organisms. Intracellular pathogens, these cannot be grown in the culture, like Coxiella burnetii, Bartonella species, Tropheriма vipelii, brucellosis. So they require serology or PCR. Okay, that's about culture negative infective endocarditis. Then occult, meaning small abscesses, often indolent. Okay, silent, and they present only with fever, and they are mainly present in abdomen. Okay, so dental can be there, apical abscess. Okay, but mainly in abdomen and liver abscess you can have, or subphrenic abscess you can have, or splenic abscess you can have, perinephric abscess you can have, prostate abscess you can have, or psoas abscess you can have. If it is psoas abscess, then you will have this thing, fever with hip flexion deformity. In psoas abscess. Okay, so by ultrasound or CT abdomen you will know that. Then osteomyelitis is in limbs. So this is frequently missed in elderly. particularly osteomyelitis of vertebral osteomyelitis, discitis. So they will have vague back pain plus fever, mainly in elderly. Okay, so that's about chest, abdomen, and lips. So other things to remember is viral and zoonosis. Viral, this is also important elderly, commonly cytomegalovirus, Epstein-Barr virus, and acute HIV syndrome. So these three present as infectious mononucleosis. Okay, infectious mononucleosis, bull-like appearance. Okay, enlarged, generalized enlarged lymphadenopathy you will have in the patient with fever, with sore, along with sore throat. So cytomegalovirus, Epstein-Barr virus, and acute HIV syndrome. Zoonoses are all very important causes of FUO. Exposure-related infections to animals. Zoonosis is the diseases which are spread to humans from animals. Common in this is Q fever from cats. Okay, brucellosis, this is from unpasteurized dairy, from domestic animals like buffalo, cows. Okay, cat scratch disease from Bartonella henselae. Leptospirosis from rats, rodents, from the urine of these rodents, especially in rainy season. Okay, or those who have exposed to water. Then toxoplasmosis. Okay, so cat, number one is cat exposure. Okay, two is domestic animal exposure, water exposure to rodents, and toxoplasmosis. So these are the causes. So what is the important thing here? So these respond to doxycycline. If you give the typical cell wall breaking antibiotics, even if you give meropenem or colistin, that will not act to this. Okay, that's important to remember. So the first one we have discussed, that is infectious causes in the big three of FUO. Okay, now we will move on to the second cause, that is not non-infectious inflammatory diseases. Okay, in that you can remember it as, number one is Jets arthritis, adult onset steel disease, SLE. Okay, sarcoidosis is one thing we should add, and autoinflammatory syndromes. So you can remember this as GASSA, GASSA, GASSA mnemonic. Okay, so what is J for and Jets arthritis, A for adult onset steel disease, S for SLE, S for sarcoidosis, and A for autoinflammatory syndromes, GASSA. Okay, so let us discuss one by one. Giant cell arteritis. This is a vasculitis of medium or large arteries. So major cause in more than 50 years of age. This may present as silent giant cell arteritis. That is nothing but patient will have constitutional symptoms only, like fever, weight loss, malaise, plus elevated ESR and CRP, and you may not have headache and jaw claudication, which is pathognomonic of giant cell arteritis. Headache and jaw claudication. What is this jaw claudication? So the patient chews food, no, he will experience pain when he chews the food. So that is jaw claudication. Experience pain in the jaw when he chews the food, in the masseter muscle. So headache, particularly this temporal headache and jaw claudication. If it is there, then that is GCA, but you may not have this. Okay, adult onset still's disease. So there will be high spiking fevers, quotidian. Okay, more than 39 degrees Celsius. One thing, high fevers. Okay, quotidian, meaning every 3 or 4 days. Okay, and there will be this is the first thing. Second thing is evanescent salmon pink rash, meaning you will have a pinkish rash which will appear with fever and disappear with fever. Means when the fever comes, the rash will come on the limbs. Okay, when the fever goes, the rash will go. Along with that, you may have arthralgias, pain in the joints, and sore throat. Okay, that is adult onset disease. Arthralgias, fever with rash, evanescent salmon pink rash. The pathognomonic or distinguishing clue here is ferritin is massively elevated, more than 3000 to 10,000 nanogram per ml. 3000 to 10,000 nanogram per ml. 3000 to 10,000 nanogram. Okay. So third cause is, so this one you should remember. Okay. Third is SLE. So it is an autoimmune systemic disease. So fever is common during flares. Fourth is sarcoidosis, systemic granulomatous disease. So patient distinguishing clue, fever with hepatic involvement or erythema nodosum. So what is erythema nodosum? Painful nodular rash which is seen in lower legs on the shin. On the shin you will notice this. So fever with hepatic involvement or erythema nodosum. Suspect sarcoidosis. This can also be seen, this nodosum in tuberculosis. I mean granulomatous distress you can see. Okay, but if it is there, then you should suspect sarcoidosis. Autoinflammatory syndromes. These include genetic periodic fever syndromes. First cause is familiar Mediterranean fever. This is common in Middle East. Okay, so there will be recurrent fever with serositis. Seros are involved. That is peritonitis or pleuritis. Lasts for 1 to 3 days. Common in Middle East family, Mediterranean ancestry. Okay, fever with serositis in Middle East. And second is TRAPS, that is TNF receptor associated periodic syndrome. Longer fever episodes or weeks, TRAPS. So that's about the causes, the second of the big three. CASA is the mnemonic to remember this one. Okay. Now the third of the big three is the neoplasms. Okay. Number one cause is lymphoma, Hodgkin lymphoma or non-Hodgkin lymphoma. The second is intravascular large B-cell lymphoma. Okay. Third one is renal cell carcinoma. Fourth one is atrial myxoma. Fifth one is hepatocellular carcinoma. Okay. So this is chest, these two are abdomen, and this is the reticuloendothelial system. Okay. So coming to the first one, the lymphoma and the intravascular large B-cell lymphoma. So Hodgkin non-Hodgkin lymphoma, fever as a B symptom. This is made by interleukin 6. Distinguishing clues often associated with night sweats, very important point. Okay, night sweats and weight loss because of and there will be systemic inflammatory response. SARS. Intravascular large B-cell lymphoma. This is a rare and aggressive subtype. Lymphoma cells confined to the vessel lumens. This is invisible on CT and MRI. Diagnosis requires random skin or organ biopsy. Then renal cell carcinoma. So this is, fever is a part of paraneoplastic syndrome due to interleukin 6. Approximately 20% of cases. Associated with, this is important, erythrocytosis. Why? There is increased erythropoietin production from the renal malignant renal cells. And hematuria. And this hematuria will be painless. Painless hematuria is dangerous. Painless hematuria. Okay. So painless hematuria along with erythrocytosis. Second cause in abdomen, hepatocellular carcinoma. Often arises in cirrhotic liver. Okay. Fever accompanies hepatic dysfunction. Then atrial myxoma, which is in chest. Benign cardiac tumor. Constitutional symptoms because of IL-6 release. So this can embolize tumor. One differentiation is tumor plop on auscultation. That is the differentiation. So that's about the third of the big three. Okay. So number one is lymphoma, Hodgkin or non-Hodgkin. Okay. Night sweats and weight loss will be there along with constitutional symptoms. That is a very important distinguished feature. Then intravascular large B-cell lymphoma, then atrial myxoma, renal cell carcinoma, and hepatocellular carcinoma. Okay. So we have discussed about the big three. Now coming to the little three. Okay. In little three, remember just three: drug fever, factitious fever, epidural hypothermia. So drug fever, it is a hypersensitive reaction, can occur soon after starting or even years into therapy. How do you distinguish? Common culprits include antibiotics like beta-lactams and sulfonamides, anticonvulsants, and allopurinol. AAA. Antibiotics, anticonvulsants, allopurinol. So one clue is you may have eosinophilia along with a rash in 20% of patients. This resolves within 72 to 96 hours, meaning 3 to 4 days after drug cessation. So these are the clues to drug fever. Then coming to factitious fever, patient-induced artificial induction of fever or thermometer manipulation. For some reason, patient will do this. Okay, for some gains, the patient will do this. Artificial induction of fever. What are the clues? Pulse temperature dissociation is a very important clue. Pulse will be normal, the patient will have fever 80, 72. This is not there, no. So pulse temperature dissociation. Then absence of rigors and sweating. There will be no sweating. There will be no rigors which are associated with fever. And bizarre temperature charts, and mainly seen healthcare background. The patient will have a healthcare background. Okay, that's the second thing. In fact, second fact is fear. Little three. Third of the little three is habitual hypothermia. The patient will have an exaggerated circadian temperature rhythm. Seen in healthy young women and it is a diagnosis of exclusion. Okay, that's about the, so in drug fever, common drugs which are involved. So you can have eosinophilia, you can have rash, and it will disappear with discontinuation of the drug. So we have learned about big three, little three. One more you add to your FUO, that is other three. Okay. So first one is big three. Second is little three. Number three is other three. Okay. So this is other three, which is I am discussing now. This is other three. In other three, number one is thromboembolic disease. Second one is thyroiditis, subacute or decurrence thyroiditis. That nothing but this is usually post-inflammatory thyroiditis due to a viral infection. Okay, and the third one is hematomas. Coming to thromboembolic disease, mainly due to deep venous thrombosis and pulmonary embolism. Okay, recurrent showers of emboli may present with fever, often overlooked if there is no respiratory symptoms. Distinction close. Thyroiditis or subacute or decurrence thyroiditis, it is an inflammatory thyroid condition often presenting after a viral infection. Patient will have anterior neck pain with fever, often self-limited. Hematomas, fever due to resorbing blood. This is usually seen post-trauma or surgery. Distinction clues, there will be history of trauma or surgery, localized findings depending upon the site. So this is about other three. In other three you will have thromboembolic disease, thyroiditis and hematomas. So this is the summary chart, causes of fever of unknown origin, infograph. Okay, one chart, see here. So in the big three you have this infectious, neoplastic and NIIDs. Okay, and the little three you will have this one, drug fever, factitious fever, habitual hypothermia, and other three you will have this thromboembolic disease, thyroiditis and hematomas. Let us see last thing. So in infectious disease, tuberculosis is important, and next thing is infective endocarditis, occult abscesses, osteomyelitis, viral and zoonosis. In neoplastic, lymphoma, Hodgkin, non-Hodgkin, or intravascular myxoma, this is a rare, renal cell carcinoma, hepatocellular carcinoma, atrial myxoma. Okay. In the NIIDs, it is GASSA, giant cell arteritis, adult onset still's disease, SLE, sarcoidosis, and autoinflammatory syndromes, familial Mediterranean fever. Okay. Little three, drug fever, factitious fever, and habitual hypothermia. Other three, thromboembolic disease, thyroiditis, and hematomas. So I think this is enough for today. We'll meet in the next video. Thank you.